Hello. Today I'm going to talk to you about the approach to reduction mammoplasties, or more commonly known as breast reductions. My name is Gabriel Cooper, and I'm a second-year medical student at the University of British Columbia. I have made this video with Dr. Janine Roller, a plastic surgeon trained at the University of British Columbia. We'll go through basic breast anatomy, important features on history, and what to look out for when you perform a breast exam. We'll also touch on two of the most common techniques, the risks and complications that accompany the procedure, and finish with the post-operative plan. Starting with the anatomy of the breast, most superficially and central, we have the nipple areolar complex. The structures within the breast consist of its parenchyma, divided into lobules, which contain glands, ducts, vessels, suspensory ligaments, and nerves, all of which are surrounded by adipose tissue. Deep to these structures lies the pectoral muscles. As with any surgical procedure, it is important to know which vessels supply the tissue and their location. The breast has two main arteries and their perforators that supply the tissue. Medially, there is the internal thoracic artery, also known as the internal mammary artery, while laterally, there is the external thoracic artery, also known as the external mammary artery. These two vessels have many perforators that form anastomoses with each other around the nipple areolar complex, which is seen in this diagram. In order to maintain blood supply to the nipple areolar complex, small blood vessels or perforators need to be preserved to avoid tissue necrosis. The group of perforators that are preserved to maintain blood supply to the nipple areolar complex depends on the patient's breast anatomy and measurements. The breast and surrounding skin are innervated by branches off the 2nd to 6th intercostal nerves, with the nipple and areola receiving its innervation from the 3rd, 4th, and 5th intercostal nerves. If these nerves are damaged during surgery, it can lead to sensory loss or dysesthesia. Some indications for breast reductions are bilateral macromastia, congenital asymmetry, contralateral asymmetry following breast cancer surgery, secondary back, shoulder, and neck pain, shoulder notching from bra straps, inframammary intertrigo, difficulty with exercise, low self-esteem, or trouble fitting into bras and clothing. In addition to the standard medical history, a specific breast history should be taken. Duration of symptoms, history of breast masses or malignancies, previous breast surgeries, last mammogram and its findings. Is there any history or future plans for pregnancy? Has the patient breastfed? What is their largest, current, and desired bra size? Current or past use of contraceptive pills, intrauterine device, or hormone replacement therapy? Lastly, the patient's reported nipple sensibility should be recorded. Next, factors that can affect wound healing need to be asked about, such as smoking, diabetes, bleeding diathesis, and coagulopathies, such as easy bruising, spontaneous bleeding in joints, or history of deep vein thrombosis or pulmonary embolism. The Caprini Risk Assessment tool is used to guide appropriate management for patients with a concern for clotting, while if there is a concern for bleeding, a hematology referral is warranted. It's very important to take your time during the breast exam, as there's a lot of information that needs to be collected. Starting with the skin quality, are there any noticeable striae, scars, dimpling, or signs of peau d'orange? Take note of the size, shape, and symmetry of the breasts and chest wall. Are there any signs of hypermastia, such as shoulder notching or inframammary intertrigo? The different grades of ptosis are as follows. Normal or no ptosis is classified as grade 0 and is defined as the breast that has the nipple and parenchyma sitting above the inframammary fold. In grade 1, which is minor ptosis, the nipple lies at the level of the inframammary fold and above the lowest contour of the breast. In grade 2, which is classified as moderate ptosis, the nipple lies below the inframammary fold but remains above the lowest contour of the breast. And in grade 3, which is classified as major ptosis, the nipple lies well below the inframammary fold and close to or at the lower contour of the breast. Lastly, pseudotosis is when the breast parenchyma is the main contributor to the degree of ptosis, while the nipple still lies above the level of the inframammary fold. This can still be an indication for breast reduction. Next, the breast and axillary regions are examined for any palpable lumps or nodes which could potentially suggest a malignancy. Important measurements that should be taken are sternal notch to nipple, nipple to inframammary fold, nipple areolar complex width, nipple to sternal midline, and inner nipple distance. When it comes to the surgical technique, the surgeon will take into account the patient's BMI, breast measurements, and the amount of anticipated nipple areolar complex repositioning. There are two aspects to consider when performing a breast reduction. Firstly, which pedicle or blood supply you will preserve in order to keep the nipple areolar complex viable. This will depend on the sternal notch to nipple distance and degree of ptosis. Secondly, the pattern of skin and parenchymal reduction. The two most common methods are the WISE pattern, which leaves an inverted T or anchor scar as seen on the left, and the vertical pattern as seen on the right. There are several preoperative marking techniques which will depend on the patient's breast size, desired volume, and technique the surgeon chooses to use. For some patients that have long nipple to inframammary fold distances that desire a small post-operative breast size or have impaired blood flow, a free nipple graft is performed. The disadvantages to this technique is there will be a loss of nipple sensation, lactation potential, poor projection, and possible depigmentation. As with any surgical procedure, general complications can arise, which include bleeding, hematoma, infection, seroma, deep vein thrombosis, pulmonary embolism, and wound dehiscence and delays in healing. Early breast-specific complications are skin flap necrosis, fat necrosis, compromised nipple areolar complex vasculature, and altered sensation, followed by later complications which include asymmetry, poor shape and/or nipple position, scars, and under or overcorrection. Lastly, between 65 and 91% of patients in the three articles listed below reported being able to breastfeed after breast reduction surgery. So, it's important to counsel the patients that there is the possibility of losing some, if not all, lactation potential. Finally, we'll talk about the post-operative care. The breast incisions and sutures can be covered with either adhesive tape or dressing in the operating room. If the surgeon uses drains, they are usually removed during the first post-operative visit, which is typically within 1 week of the surgery. Physical activity should be limited for at least 2 weeks, while normal activities associated with daily living can resume after the first post-operative visit. Scar management will be reviewed. For the first 2 weeks and until the scars are healed, a non-wire bra should be worn. Serial follow-up visits will assess final breast shape, symmetry, and nipple areolar complex sensibility. This brings us to the end of our presentation on reduction mammoplasties. We hope you found this video helpful and continue to watch future videos like it. Thank you for your time.